I'm Richard Geer, Physician Chief of Surgical Oncology at Sarah Cannon. And I think what we're looking at this country is now we're starting to get better genetic markers for tumors. And so as we look at those markers, there is a test called BRCA1, BRCA2. About 10% of breast cancers are associated with these BRCA genes. And it gives a woman a lifetime risk of about 80% of developing breast cancer, about 40% of developing ovarian cancer. So it really, and depends on the type, but so it's important to know if you do have a direct family history, your maternal grandmother, your mother, her sisters, you know, it kind of goes straight down the line in terms of that. And that makes you at high risk. So risk of having breast cancer is important, and that's important to talk with your physician as well. If you do have a risk of family members with it, it is very important. We find that younger women that develop breast cancer generally often will have a little bit more aggressive cancer. And again, we talked about offering them mastectomy more than radiation therapy, some of those women, because it's going to be, again, the statistics are they can do well with this. And if they do well with this for 40 or 50 years, we want to give them the best result that they can have in terms of that period of time. And sometimes mastectomy with reconstruction may be that choice. The other thing about mastectomy reconstruction, I kind of back up a little bit, mastectomy reconstruction is important, but the one thing I want women to understand is that even though the breast in your clothes looks like you, it won't feel like you. It doesn't have sensation like a normal breast does. It feels more like there's a filler that's been placed there in terms of the chest wall. And I think that's important. I think that some women have a body image that if they have it done, it's going to be this, this look that they've been trying to obtain to make it really look better. And it does, but it's not going to quite be what you've been used to. And I think that sometimes the reality of the thought of it initially and the reality is sometimes a little bit not together. And I think one of the important things is that you really need to ask them if you're considering doing a mastectomy and they want to do what's called a prophylactic mastectomy, to remove the breast from the other side. The question is, what is your real risk of developing breast cancer in the other side? Because oftentimes the reason why we're going to take out the one side because we know it has a tumor that has characteristics that we can't control with lumpectomy, or it's a choice to do that. But the reason is, why do we want to take out the other side? What's the risk to the other side? And if you ask women what their risk is and the reason why they had a prophylactic mastectomy, they'll overestimate their risk by 10-fold. And this is important. Basically, the risk of 10 years of you developing a tumor in the other side for most women without genetic history and other things is about 3.5%. And if you ask women what their risk is, they will tell you 35 to 40% in 10 years, and that's why they made a decision to take out the other side. Do I have to have chemotherapy? And often people will come in. Unfortunately, when you get diagnosed and when you go through this, this is not something that's going to take a day or two in the office to have done. This is a 6-month to a year to a lifetime journey about being treated. I mean, you now have breast cancer. You now will be a survivor from breast cancer, but it takes a while to get this done. So the surgery component will take a couple of weeks, let you recover from that. The radiation component will take about anywhere from a week to 6.5 weeks. And then the chemotherapy component may be some form of IV chemotherapy which is given, which could take literally months, 4 to 6 months, sometimes a year. And then you would take another pill that you take for 5 years. So this is going to be a journey. It's not a go in to have surgery and you're through with having surgery. So it's a much longer process in terms of that. The question is, who needs to have chemotherapy? And the studies have been done. They looked at any tumor basically greater than 1 centimeter in size. The women who had chemotherapy versus the women who didn't did better. So there's our breakout. So that's what we want to know. And the tumors that are less than 1 centimeter in size, oftentimes we'll look at genetic scoring, either the Oncotype DX score, the Herceptin score, the HER2/neu score, or the ERPR score, and then make a decision. Are you at sufficiently high risk that you would benefit from that? So oftentimes this will be a medical oncology consultation and then make a decision with them. About 10 to 15% of patients are treated through an academic medical center where you have very specialized people to treat you. However, the majority of patients that are treated with breast cancer are treated in the rest of the United States, 80%, and you may just see a general surgeon. You may see a general surgeon who likes to do breast. You may see a general surgeon that basically specializes in oncology and some that just focus on breast only. So depending on who you see gives your level of comfort as to where you go. And what the goal is to really ask questions and really to be your advocate along the way. If you're uncomfortable that you haven't had enough information, you just need to go back and call the surgeon back. And if he's uncomfortable with giving the information, it's time to probably go take a look for another option as well. In treatment of breast cancer, you'll find there's a number of advocacy groups, and they're all here to try to help you in your journey through this very difficult time. And it doesn't become easier over time, it becomes different. I think that's the best way to describe it. And so there are groups, and the minipearl.org is one of those foundations that visit the website. They have a lot of supportive information that can help you through your journey.